Right, Chair, if you want to start the meeting.
Good evening and welcome to this virtual meeting of the Health Scrutiny Committee, held by virtue of regulations introduced by the government in April 2020. I'm Councillor Shoaib Akhtar and I will be chairing the meeting. The regulations have temporarily removed the legal requirement for local authorities to hold public meetings in person, but enables councils to still make effective and transparent decisions on the delivery of services for residents. The requirement for public meetings to be accessible to the public remains, and the link to this virtual meeting is available on the council's website in the usual meeting link page. If a connection to a member is lost during this meeting, I will stop the meeting to enable the connection to be restored. If the connection cannot be restored within a reasonable time, the meeting will proceed, but the member who's disconnected will not be able to vote on the matter under discussion, as they would not have heard all the facts. Just 1 minute. Should any aspects of the external link fail, I may call a short adjournment of up to 5 minutes or so to determine whether the connection can quickly be re-established, either by video technology or telephone in the alternative. If the connection is not restored within that time, the meeting will be adjourned and any further business will not proceed until another time and date. Firstly, can I ask the clerk to ask the members to confirm their attendance, please?
Councillor Elias.
Present.
Easy.
Just managed to get in time.
Councillor Byrne.
Present.
Councillor Hamblett. Councillor Hamblett.
Apologies, present.
Councillor Ibrahim.
Present.
Councillor McLaren.
Present.
Councillor Torr.
Present.
And Councillor Akhtar.
Present. We also have representatives from Oldham CCG in attendance, along with council officers from Children's Services and Constitutional Services. If the committee is required to take a vote on a report for approval, or we are making a substantive recommendation, each member will be individually asked to state whether they are for, against, or abstaining. When a report is for noting, I will only ask if any member does not agree. As with all committee meetings, should it be necessary to exclude the press and public, once the exclusion has been moved and agreed upon, the press and public will no longer be able to view the meeting. If we can now turn to the agenda, and for the benefit of those members of the public watching, the full agenda pack is available on the council's website. Item 1. Do we have any apologies for absence?
Councillor Cosgrove.
Thank you. Do we have any urgent business? There are no items of urgent business. Sorry, Mark. Item 3. Do members wish to make any declarations of interest? No? Right, we move on to item 4. Have we received any public questions?
We've received no public questions for this meeting, Chair.
Let's swiftly on to item 5 then. Members have before them the minutes of our last meeting. Are these agreed as an accurate record?
Move the minutes, Chair.
Thank you, Councillor McLaren. Is that agreed?
Agreed.
Agreed.
Thank you. We'll move on to item 6, which is the first report this evening, which is urgent care review being undertaken by Oldham CCG, and presenting the item this evening. Would we have in presence, Mark? Is it?
I'll deal with it, Mark, if that's all right. So, hi, Councillor Akhtar. My name is Mike Barker. I'm Strategic Director of Commissioning for the Local Authority and also the Chief Operating Officer for the CCG. And joining me is Nicola Hepburn, who's Interim Director of Commissioning Operations with the CCG specifically. As I understand it, the committee wanted to hear an update from us about where we were with the Urgent Care Centre. And we've also taken the opportunity to, first of all, just broaden that out a little bit to give you more fuller picture And secondly, just to kind of put that in the context of the COVID-19 pandemic, I thought what I'd do if it was helpful is just quickly walk you through the paper. I'm not going to do it line by line. I'm sure everybody's had a chance to read it. Both Nicola and I have had a chance to do some thinking over the past couple of days, and it'd be helpful, I think, if Nicola took you through some of the patient pathways specifically, and then perhaps, Chair, if we open it up to questions at that point, just to kind of give it a clear enough run for people to ask what they need to ask
Sure.
at the end of our little presentation. So without further ado then, I'm not so sure how familiar our members of the committee are with the background to the walk-in centre in particular, but certainly before my time in Oldham, there was quite a lot of pressure nationally in 2009 to provide additional urgent care primary access to stop people using emergency departments. But then further guidance was issued prior or further to that, and then around about 2016-17, that any walk-in centre should be moved into an urgent treatment service. And it's my understanding that Oldham CCG at that point sought a consultation on what a walk-in service would look like in a more urgent setting. Since that time, of course, we've had the COVID-19 pandemic, and all CCGs were required to immediately set up a COVID assessment centre, or what we describe in more colloquial language as a hot site. And that was to stop all walk-in access to primary care facilities, given the concern about the spread of the virus. Equally, we moved our out-of-hours service from the hospital to the integrated care centre in the town centre, which is where the walk-in centre was based, and we relocated our GP working in the emergency department into the COVID assessment centre in the ICC. Both, or all of that combined, was in replacement of a walk-in centre and fully in line with the national guidance to shut those facilities down and replace them with something that could be more controlled to stop the spread of the pandemic. On March the 29th, we finally closed the walk-in centre and we moved into a new system, which was the COVID assessment centre, that introduced new infection control measures, but also additionally added a digital element to the site. So what people will have heard more and more over the past couple of months is the health service moving away from face-to-face consultative process and clinics into a space where there's a lot more digital services and facilities available to people. And our COVID assessment centre that replaced the walk-in centre was our way of dealing with that. We also then at the same time expanded out its reach, and the digital aspect of that centre and service was put in place to support care homes as well as other home care providers, and using digital technology in a way that we've never done previously. So what we've been doing as part of managing the pandemic is closing down the amount of, in the early days, the amount of walk-in access that was unregulated and uncontrolled, and replacing it with a much more controlled infection environment in which we offer an additional set of digital access elements to patients. Given that we're operating in the same financial envelope, we had limited opportunity really. So our way of dealing with that was to use the ICC, where the walk-in centre was based, as a facility, because we could better manage patients through that, and the technology was already there. But to make that a more effective solution, we've transferred more into it and expanded its horizon so it deals with different things through this pandemic period. Of course, we're now coming out of the pandemic and we're starting to think about the restoration of services, which I won't get into in this committee this evening. But where we're currently at was moving from a national direction to shut all walk-in facilities down, replace them with effectively infection prevention control measures and digital access services as a vehicle to do that. And that's broadly where we're at with the walk-in centre. Probably the best thing I think to do now, Chair, is just get Nicola to walk through some of the patient pathways as to what that means in real life, rather than just words on a bit of paper.
Okay, thanks, Mike. Thank you there. Evening, everybody. So we have shared some of the PowerPoints as an appendices with the paper. What that does is take you through some real life examples of what has happened. If I talk broadly to you about the types of patients that we're seeing and actually that what benefits that's caused and equally what that has done for our system. So where we've been trying to get the acute hospital to reduce outpatients, work with primary care to deliver care closer to home, the digital hub and the COVID pandemics has allowed us to escalate and accelerate how we get this done. So in a case where we would normally have somebody, for example, care home who's very unwell, the GP's not been able to treat them and has needed a second opinion or some advice, what normally would happen is they would either go through 111 or through 999, an ambulance, a long wait in A&E, and then not to know whether or not that individual gets admitted. But very rarely does that individual get to go back home and have the care and treatment. We all know what that means. It disrupts the patient pathway. It can be very traumatic. People that are older, confused, or very unwell, it's a very scary time. What the digital hubs allowed us to do is the care home, for example, are able to ring 111. They get an appointment directly with the digital hub. They go through a video consultation similar to this. The patient has access to all of the care staff, all of the care records, and be able to visually see the patient that they're talking to, do an online clinical assessment. And in some cases, that would still mean that there's a transition into hospital, but it would be in a pre-booked bed, save the delays, and at a time where the staff are able to wrap around care around them. Or it would be that there would be an onward referral, some care and treatment at home from the community services. So, for example, dehydration is a big concern for us in care homes. Rather than going into hospital, actually what we've been able to do is put a care home service in place where the district nurses, community teams have been able to go out, visit the home and put some rehydration therapy in place. So from a patient perspective, not had to get admitted into hospital and has had a wraparound care. We've had other examples where there's been a review of somebody that's needed ongoing diagnostics through the GP. That's not worked. Ordinarily, what would happen is they'd go to the walk-in centre or go again directly to A&E. What's happened is there's been a video consultation and we've had a second opinion. So again, somebody's had an outpatient appointment as opposed to having to wait through A&E. And also there's been a lot of online prescribing so that they've been able to do a virtual advice and guidance, prescription done, and then the patient's been able to go directly to the pharmacy and collect their prescription. We are now starting to see the impact. So we've had the first quarter of this data. We've also seen, and what we're getting is the anecdotes around patient satisfaction has improved. They've not had the delays. Certainly from a care home and for people that are most vulnerable from the community teams, they're seeing an impact. But again, we're just seeing that data and we're just starting to collate it. So I would expect that we'd be able to bring that back to you the next time we come to share that with you. But that's the types of pathways and the journeys that people have been taking, and I'm happy to take some questions. Thanks.
Sorry, well, I'm just coming off mute. Thank you for that, Mike and Nicola. Are there any questions from members? Have you all been able to see the patient journey paper? Yes, no?
Yeah.
Yeah, right, okay. Councillor Hamlet?
Thank you, Chair. It's really great to actually read about this and also hear directly from both Nicola and Mike as well about the forwarding steps of how this has been taken, and particularly regarding the ICC, which in actual fact what I see it as is a bit of an essential and especially an integral part of our care systems, particularly how the fact that for a lot of folks, it's a lot easier to get to if you don't drive than it is our hospitals. However, one of the things that I've found is for a lot of folks, particularly in my neck of the woods, it's not necessarily as easy to just bob online like I am now and get in touch with your doc or your nurse or whoever and just say, look, my eye's a bit dodgy. Can you have a look in my eye and have a check? I've got something in my eye because I was cutting some leaves and I've got some foliage in there or whatever else. I've just a classic example. I've got a lovely young chap. He's not really, he's 70 odd. And he can't work his laptop. He's constantly complaining at me. He's going to lob his laptop out the window. And Ken, bless him, he can't really work his phones. But you know what? How can we really assure our over 50s, over 60 odds to say this stuff is safe? Don't worry, your doctors are there, even if you can't knock on the door and go and see them. Because at the end of the day, a lot of people, especially in Oldham and especially up in my neck of the woods, are more face-to-face folks. They just want to go up and speak to somebody. And I get that we are currently in a world where speaking to somebody is at risk, especially for them. But we need to be able to say that service is there, but it's not physically there. So how can we ensure that at least that line of communication is going to be open for them and it's not entirely disappearing, because we can't limit these people?
So I think it's a really good question, Councillor Hamblett. I think if there's anything good that could have come out of a pandemic, I think it's the NHS's ability to embrace technology and roll it out at pace, and then offer people a different means of accessing services. However, we also have to accept that the health service is always going to need to see people on a face-to-face basis. And I think what we're now getting to is a much richer mix of digital and face-to-face opportunities for people. The ICC has always been a fairly interesting proposition ever since I came to Oldham 2 years ago. It baffles me why we want 200, 300, 400 people plus every day rocking through an emergency department in the middle of the town centre when we can't really manage the infection control mechanisms effectively. So what by changing the status of the walk-in centre and do something different, it's allowed us to be able to say to people with some certainty, we can help with your safety and see you face to face. And for those people that want that facility, it's now there for them. But equally, those that want to alleviate some low-level concerns, take their appointment digitally in the first instance and have that reassurance that actually things are fine, but we'd still like to come in and see us, then we've also got the opportunity to bring them into the centre as well and do it in that way. I think what you'll find more and more now as we enter into this period of time is that we're bringing back services in quite innovative ways and different ways that allows people to not just access digitally, but we get back to face-to-face appointments, which is what we really need, Councillor.
Thank you for that, Mike. I've got three other members that have indicated. So can you take two questions at a time, and then if one of you could respond to that? Councillor Ibrahim, and then Councillor McLaren, and then Councillor Alias.
Thank you, Chair. Thank you, Nicola. Thank you, Mike. This pandemic obviously has shown us all a change, and the services that are obviously being shown in this digital hub will be a way forward, I think. I think it gives, especially patients that are vulnerable, especially patients in care home, which do find it very difficult. And I think it's very distressing for those patients, will be a way of accessing the services very easily. And again, it's not just for those patients, but patients that working patients that can't actually get into appointments, I think is easy access. And it does save a lot of the walk-in, and it's about infection control. Whether it's the pandemic or not the pandemic, I think we were having a lot of people with infections that were using those services that we can actually control a lot better. So it's all about change, and I think this pandemic is showing us that now. So at the end of the day, we've got to move with the times, I suppose, and we're having to do it. So let's go with it and let's see what it brings us.
Let's embrace it, yeah.
If we look in the round, I think it's shown us that, the days of people waiting in GP surgeries at the back end of the day, having phoned in the morning to get an evening appointment. And, you know, for those that couldn't get that, then using a walk-in centre, those days are disappearing. People want more convenience and want to be able to access in a much more safe way and easy way. And hopefully what we've found is a balance between the two things. And of course, the more this goes on, the smarter we'll get at being able to run these services in a really effective way. But this is a really good start, and we've learned an awful lot in the space that we've had so far.
Councillor McLaren.
Thank you, Chair. I'm going to stay with the same theme, I'm afraid. We've known for a long time that we haven't been able to encourage people not to go to A&E. The pandemic has sort of, in a sense, helped to change that pattern, but I'm not convinced that we've resolved it. In actual fact, one of the things that we've constantly been unable to do is to explain to people how the system works. And up to now, I'm not sure that we've achieved that yet. We may have achieved it for some. Those that are technologically unchallenged, shall I say, might have a way, you know, find a way forward. But those who are technologically challenged, and I'm in that group, would find the system in many respects overwhelming. And we've not found a way of simplifying things, and there is nothing that people can look at. People like bits of paper as well as technology, but there is no bit of paper that we've managed to produce that demonstrates what the pathway is or which pathway they need to follow. And we've talked about this on a number of occasions, and I've talked about my dictionary of health and social care on occasions, and we still haven't got one. You know, because there are things even in this report that you say, what does that mean? What does that, and so on. And I'm not sure that whilst we have the explanation, of course, retaining those explanations is a challenge, and sometimes you need to look them up. And I've offered before to be Mark's agent in developing diagrams, as it were, as to how the services is intended to be, you know, pieced together. And do we know what's in all the boxes? I'm not sure that we do, right? Or in the flow diagram, I don't think we do. And if we don't, you can pretty much assume that the wider community don't understand it either. And I think that is the challenge that we are facing. And again, I'm going to repeat this offer via the chair, that we will offer to work with you to find a way of addressing this problem, right? But I don't think we've got an answer yet. And it remains to be seen that when eventually the pandemic comes to an end, as to whether they all go back to A&E, because it's now safe to do so, as it were. There's no infection risk. Don't understand this, we'll forget that. We'll just turn up at A&E. I know what goes on there. I don't mind waiting 4 hours. If that's the case, I know I'll be seen, and so on. So that is the challenge that I think underlying all of this that we still need to address. But as I say, you know, I think there's an opportunity to perhaps work with this as to how we develop the publicity material that we need in order to ensure that the wider community understand what we're trying to achieve.
Okay, so I said last time I'd more than welcome your help because I only know the language that we speak. So absolutely, I think more than welcome now and to help us with how we get across the digital offer. So I will come back to you, that's for sure. I think what we have seen is that we saw a significant drop in attendance to A&E, obviously because of the pandemic. As things have started to ramp up again, we have started to see people back into the A&E, but there's a significant difference in the types of attends. So we are seeing less of the advice and guidance, the low level category 3, category 4, which is what could be dealt with in primary care, the injuries and the scrapes and the non-admitted. I think what's really important that we did, and we took the most vulnerable at first, care homes, and actually if we can keep those people, the most vulnerable, safe. Those people we've got surrounded by staff, the people that can use the technology, and what we're doing is working with families to show families that actually this is how it works. So we are doing some of those educational events as well. Because now we're starting to introduce a phone before you go work. This is something that's being done from a Greater Manchester perspective, is that people will have to ring 111 before they go to A&E, so they have to be given an appointment. What this will do is work with the rest of the general population to either book an appointment back at general surgery, and I think that's where we've always seen in Oldham, and we talked about that last time I came, is around people see it as that easy option, like you've just said, Councillor McLaren, around people just going to A&E. What we're doing now is giving them an easy option and being able to give them an appointment direct into their own general practice. So we're starting, rather than giving people information leaflets and giving people lectures on which way to go, we're starting to map against how our population works across and what their services need to be. So I think that's a real point. I think we'll see over the next coming weeks around how our population believes when we start to get local lockdown eased, that people will go back to A&E or not. What we have is we've got a stronger system where we can support patients and we have different services available. I think what we are is we're feeling more confident that we've got other alternatives that are safer and that are able to give people different offers. I think that one last point around the digital work is that we can do this over the phone, so we can triage some people out over the phone. You don't have to have IT literacy skills, you don't have to have access to a smartphone or a laptop or a tablet. We can have those discussions over the phone. What you've got is your own GP, which we know people love. They want to speak to their own surgery, they want to speak to their own GP. So we can do that triage, and we know that that is stopping some people go. Our aim is to look at least 100 people out of the emergency department on a day-by-day basis. We are getting that, we're nowhere near the numbers. What we need to do is see a sustainable model so we can hold close to our plans and aim to organically adapt them if need be.
Thank you for that, Nicola. Councillor Tor?
Thank you, Chair. I think most of the things are covered, but just wanted to point out, I mean, first of all, thank you for the presentation. It does give a really good idea, and any change is, do you always get like 50-50? A lot of people will welcome the change, a lot of people will take time, and so I think one of my questions is for a BME hard to reach group. I know the young people will be able to manage, they're probably happy, it'll save a lot of time, waiting time, but I think as a lot of people raised here for the older people, so I think my question will be similar especially for BME communities. Have you experienced anything, or what kind of facilities or services are available for them to make it easier, or services available for that particular hard to reach group? Thank you.
Who's going to respond to that?
Do you want to take it, Nicola?
Okay, so I think, it's not gone unnoted. We absolutely know, and we also know that given the risks of the pandemic to the hard to reach BME communities, we're working with Councillor Rouge. Oh, I'm so
Shaw.
sorry.
Councillor Shaw.
Thank you. We're working with Majid. We've set up a separate group to look at this in very specific detail around whether or not it isn't, again, we know, a language issue about putting a leaflet together. This is about how we help navigate around the system. So again, there's other opportunities, but it is around how we do that, and I know certainly that they're working on that. I can share it with you.
Can I just add? I think this comes back to Councillor McLaren's point in many different ways. So I think I've said this a few times since I came to Oldham. I find the system at times in Oldham very, very complicated, overly complicated. And actually what Nicola and I have been doing slowly is uncomplicating it and making it simpler. I think we've got to grasp the opportunity of changing the walk-in centre as a overall objective to simplify our urgent care system. Patients know where the GPs are and they know where the hospital is. If you've then got 50,000 things between those two, it gets very, very confusing. And what we're trying to do is just make the thing an awful lot simpler than what it was. And we're using, frankly, the pandemic has provided an opportunity to be able to do that. That said, we also need to really start to get underneath understanding people's preferences and choices. So we know now that every single day in Oldham, there's broadly a surge late afternoon for people taking children to A&E, and we know why that's the case. We need to start looking at these patterns of demand and activity use in a much more holistic and consistent way, and then start to try to design services in a way that makes sense to how people live their lives, not simply put in place services that we think should be put in place. And to do that, we've got to get into much smarter community engagement exercises, much more deeper conversations with the population, and simpler explanations about what NHS services are here to do. And that's the commitment that we've put in place, and certainly the things that we're now starting to explore in much more greater detail. The pandemic, I think, has provided, I'd like to say, a turbo boost to the way we do some of those things. We've learned an awful lot because we've had to, and I think that's a sad indictment that we've had to. We should have been doing this before, and I've certainly worked, and I know Nicola's worked in other systems where this is a bit more commonplace. And we need to be brave, embrace change, but do that smartly and in a way that engages you as local elected members, so we can communicate better with communities. Thank you,
Thank
Chair.
you, Mike. Councillor Ibrahim, did you have another question?
No, sorry. I just.
So your hand was raised.
Sorry.
Right. Okay.
Got a hand up, Chair.
I want to mention a couple of things. I think I'll take the privilege of asking. Councillor Alia, sorry, have you got your hand raised again?
Yeah, thank you, Chair, and thanks for the presentation. I think it's a really good change, and hopefully it will work really well. Just going back to the discussion that we were just having, I mean, looking at the use of technology and also looking at a large chunk of our community who have English is not their first language, and they need that language help. And added to that, where you have to wait quite a long time before you can get through to somebody to speak to. I'm just hoping that a lot of people who don't have access to decent technology or can't use it and need to have somebody there who's going to sort of do the interpretation for them. A lot of people don't kind of miss out for the consultation that they needed, and and it's not too late by the time they get to their GP, or they don't necessarily end up in A&E because they're not comfortable with some of these things.
I think it's a really fair point, and I think moving some of the access mechanisms to a digital platform certainly takes a chunk of people waiting out the system who will be sat in waiting rooms. That will take pressure off GP surgeries, for example, and reduce the amount of time, or the amount of time it should take to get an appointment, which I think can only be a good thing. Giving access to care homes in a way that we've never really done previously will take a number of people away from A&E department, which will also reduce the pressure. I think we fully accept that not everything needs to be done on a digital platform, but equally not everything needs to be done face to face. We need a good mix. We have never not encouraged in the NHS the use of interpretation services. They should be available to every single person that needs them at the point of accessing their appointment, or whatever that may well look like. If scrutiny members have issues, then by all means raise it with us and we'll look into them on a case-by-case basis. Frankly, it's not a budget that we've cut. It's not a budget we're willing to cut. But we also recognise there is a very particular challenge in some of the communities we operate in, and we need to work more closely with the local authority colleagues in how we do that going forward. And that, again, we've made that commitment and we'll continue to make that commitment. I think we can do better, and I think the pandemic's encouraging us to do better. And I think part of that is building advocacy in local communities, so it's not just the health service talking at people, but it's local people actively engaged in the dialogue with the health service and the health service responding. Thank you, Chair.
Thank you, Mike. I've got a couple of sort of questions myself. In terms of obviously, I mean, I'm all for the digital service that we looking at sort of setting up, and it has been set up, and all for the change. But one of the concerns that I have is basically around looking at, you know, pre and pro COVID in terms of why is that demand there for that urgent care? Where is it coming from? From certain, say, GP services, from certain neighbourhoods? And if so, what are we actually doing about that in terms of to reduce that demand from those neighbourhoods and from those GPs? And what is the CCG doing in terms of making sure that those GP services are actually responding to their patient need? I mean, I've had a really negative experience of my own GP, and I have reported him to CCG, to CQC as well. So in terms of, I think that there's a lot of work that we need to do there, because a lot of these patients are actually turning up in A&E and into the walk-in centre when they was there, because they were struggling to get an appointment with their GP. And in some case, I know, Nicola, you mentioned that people want to talk to love their GP, but in some instances, people don't love their GP. They don't want to go to them, to be honest with you, because they're unhelpful. So what are we doing about those to make sure that, one, that those GPs are actually trained up properly and their staff are properly trained up and meet the standards that we want in Oldham? And personally, I think there are some GP services out there who are not.
So we'll take this in two bits, I think. We're a bit off topic from urgent care, but I don't mind that, as long as you're happy.
What I'm looking at is in terms of why is that urgent care there? Where's it coming from?
Well,
if we don't deal with that, then that demand is going to increase.
There's a couple of different points, I think. So first of all, we need to look at some of the wider determinants and the situation that Oldham faces. So, you know, there's a very clear reason why Oldham, at the very start of this, had quite a steep increase in the number of COVID cases. When you look at the quality of housing, the quality of air, the number of care homes that we have in our patch, the level of morbidity and mortality rates that exist in Oldham have existed for quite some period of time. So, for example, by comparison, Oldham has quite a high number of people with respiratory disease. By comparison, there's been quite a lot of people with COPD. Smoking rates have come down dramatically, but have been high historically. So there is a reason why we have a population that consumes health services to a greater extent than other parts of, say, southern England or different parts of the northwest, and we need to understand that. 2 years ago, when I first came to the CCG and to Oldham in particular, it was the worst performing in Greater Manchester for primary care. And then a young lady called Nicola Hepburn came to join me about a year later, and we're now in a really great shape when it comes to primary care. I'm sure that's not what she'll say, but I'm certainly going to heap the praise on her and her team. But it's not been easy. You know, we've had to make some really difficult decisions about some poor performing GP practices in Oldham. And we've had to make some other decisions about really trying to support. Our position is to try and drive up standards consistently 100% of the time. And sometimes the work that we do gets that really right and effective, and other times not so. We've also got a population, though, that liked Doctor First, and there's lots of cultural issues why Doctor First is in there. And that's why we have broadly a large number of people turning up at A&E. Added to that, we've got a complex system in emergency and urgent care that we need to resolve, and that's the work that was alluded to in the paper about the development of an unscheduled care strategy. But there is no reason that I can give you of any logic that would say why 320 people turn up at an A&E department every single day of the week in Oldham. What I can tell you is that we need to take about 70 to 100 people out of that stack every single day to deal with infection control safely and to make sure that people get the right services that they have. Now, we know that a lot of people have been turned up at A&E for what I broadly describe as advice and guidance. We know that we can provide a different way of dealing with that service. Equally, we also know that the reason why it's really difficult to get hold of a GP appointment at times in Oldham is because people just want advice and guidance. And we know that if we offer alternative ways of getting that advice and guidance, it will make the appointment process for physical examination a lot easier and simpler. But equally, I would absolutely not walk past, underestimate the size of the challenge in Oldham. It's a really complex place. Its health service is very plural and diverse. There's certainly work that we need to do to simplify it, and some of that's going to come with quite broad change as we go forward. The commitment from Nicola and I and the team is that you will have all of our attention, effort and endeavour to make it as simple as we possibly can. I personally think COVID has been tragic for the country in lots of different ways, but we've got to see the silver lining, and some of that silver lining has allowed us to go a lot further, a lot quicker on some of the service redesign that we need to. I can't ignore the fact that primary care standards are not where they need to be, but they're getting better and incrementally getting better. I don't know if you want to add anything, Nicola.
Nothing more than that, thanks Mike. Just to say that in October we are starting a quality assurance framework, of which visits, referrals and appointments are going to be reviewed at every single practice. That takes on board not only how the staff work, but also patient experience and getting those feedback. So from October, for the following 6 months, every single practice will have been through that, given the support in order to improve their quality assurance in line with CQC. So again, I'm sure the next time we visit you and join you, we'd be able to talk to you about that in more detail, but we are starting to get that detail. Thanks.
Okay, can I make a suggestion in terms of, I mean, I work in the housing sector, and within the housing sector, we have like mystery shoppers, and who would walk into your office and say, okay, we want this information or that information. Could we have a similar kind of service set up?
We have it.
It's there.
Okay, and then what outcomes have you achieved through that in terms of which GP practices are being targeted? I mean, I don't want you to be naming them. Obviously, we're in a public meeting at the moment, but
so we've I mean, in simple terms, we've ended up enforcing regulatory action on 2 practices. That's resulted in the revocation of licence to practice for those 2 practices. We've also seen one other practice where we've put intensive scrutiny into them. We've put additional resources in, and we've seen them go for inadequate to good within a matter of 6 months. I don't think there's any practice now in Oldham, any GP practice in Oldham that is inadequate. I think we have 3 that are still requires improvement. Everything else is good. I'm looking at Nicola for comfort around that particular position, but that's how it is in my mind.
The one part that we have done around the mystery shoppers is the telephones. So we know a lot of the reasons why people will make alternative choices, whether that be A&E or somewhere else, is that if people try more than 3 occasions, can't get through on the phone, so they go and queue and get an appointment elsewhere. So we've got that. We're working with all of the practices around what it looks like for telephony, standard operating procedures. So we are working with them. It just, as with everything, takes time. What we have done is obviously people that we are more concerned with will have a visit sooner in the list rather than wait until next year.
Right. One last point on that, and then I'll move on. In terms of, you said that you've taken action against 3 practices. Was that action taken as a result of the work that was done by CCG, or was it as a result of the work of the inspection carried out by CCQ or CQC? Sorry.
Combination of all of those things.
What I want to see is the CCG sort of stepping up and providing that necessary support to those practices to make sure that they adequately they got the right type of resources and the right type of training is being provided to them, rather than, I don't want practices to be closed down or etc., because we're under pressure to get good GPs to come into Oldham as it is, and if we lose those GPs, then we're going to struggle even further. So I'd rather have support mechanisms put in place to make sure that those good practices are carried out, to be honest with you. One last point is that I'll share this with you in terms of one particular, I've provided information on that particular practice. I had a phone call this morning from one of my constituents. They had rang up 100 times this morning to get an appointment and they couldn't get through. They made 100 phone calls. Whether that individual was exaggerating or not, but he specifically said to me that he rang up 60 times before a certain time and then 50 odd times after that time. So I'll share that information with you offline, basically.
Yeah, dude, that'd be really helpful. And I think, just to reassure you, our position is that we want to see practices thriving. We don't want regulatory action enforced. It's too late at that point in time.
Yeah.
But equally, nor can we walk past poor performance where poor performance exists to the point of something needs to happen. I think we've got to get to a place where local people are much able to voice their concerns about things that they're unhappy with. From my point of view, someone who doesn't live in Oldham, I live in a place where people are far more vocal. People need to be a bit more vocal about what they expect and the standards expected of them, and we need to find a way of harnessing and encouraging that. And that's undoubted. But we've got to get to a place where
in the BME community, you're not going to get many patients putting complaints in about their GP. To be honest with you, it's just down to the respect that they have for their GP and etc. They're very hardly likely to put any complaints in. So my particular GP was boasting that his practice had the least number of complaints, and I know why.
Yeah,
because my sort of, like I said to you, the service that I got from him was pretty poor, and people were complaining about that before, and I said, look, he seems to be fine, because I didn't need him then. When I needed him, he was like nowhere to be seen. But we'll move on.
Councillor Hamlet's got his hands up. Councillor Hamlet.
Thanks, Chair. It was just partially on the back of what you were saying, but also the fact that I'm surprised that the majority of the majority of the GPs that you're getting are actually being rated as good as such, considering the fact that I know of at least a few that have PPGs that aren't meeting the one that I'm at. The PPG isn't meeting. In fact, I haven't met for over 2 years. Surely the CQC doesn't actually should be rating it as inadequate, or is that the fact that my particular doctor actually belongs to the Chief Clinical Officer of Oldham Council? But I don't know, because I'm just a mere mortal. But however, I'm just I suppose perhaps maybe I should just report that to CQC. However, in normal circumstances that will be the case, but of course because we're in a sort of semi-lockdown, that could be forgiven. However, after that, I suppose it would be flagged up. But in this case, it has been some time since this particular practice hasn't actually had sort of a PPG. Now, putting that aside, it is a reasonably run, well-rounded, a surgery as such. I get the point that you're making, Chair, but I do think that these things will have to be seen at the later report, and I think it'll have to be poured over and macinated when we go on. But I just think I was quite surprised at the number of doctors that we are getting as being rated as good, considering those little steps are being sort of missed. So I just don't know how many boxes are being ticked or not quite ticked as and when they come up.
Well, we don't rate them, Councillor Hamlet. The CQC rates them. So, and my experience is they're pretty thorough when they go and visit. However, if you've got a practice that's not got a PPG, then we want to know about that, because they need to have one. Now, whether they choose to organise that across the group is a different matter, but we'll pick that up offline.
Okay, I'll let you know.
Thank you.
Councillor McLaren.
Just to come back to the point, I know we need to move on, Chair, but just to come back to the point that I made about how we begin to address the communication issue, if you like. I know Nicola sort of said that she was happy to, perhaps to meet to discuss that, and maybe we should follow. I wonder if we could follow that up, Chair.
Yeah, definitely. Yeah. So, is that okay with Nicola and Mike to follow that up?
If we do that through council officers, Councillor McLaren in the first instance. Yeah.
Well, I'd like to involve the chair as well. It's
Yeah.
You know, if that's okay. Yeah.
Yeah.
Sure.
That's great. Are there any further questions to Mike and Nicola? No? Mike and Nicola, thank you very much for the presentation and coming along to our
Thank you.
scrutiny meeting this evening. And I hope you'll come back again in the future. I hope we've not given you a hard time. So, well, thank you for that.
Never. Thank you.
Okay, thank you very much.
Take
And
care. Bye.
And the report is
Bye.
noted.
Bye.
Thank you very much. Move on to the next item. You're more than welcome to stay with us if you want to, or you can leave if you want to. Just moving on. Can't move my agenda down now for some reason. Right, next item is item 7. It's to do with early help strategy, and we've got Bruce Penhale with us, who's the Assistant Director in Children and Young People, here to present the report to us. Bruce?
Okay, thank you, Chair. Those you maybe remember, sort of been on the committee for a while, might recall that we've previously been talking about Oldham Family Connect. We're moving on now to talk about a multi-agency early help strategy, and I'll explain a little bit later, sort of about why we've made that move. So just in terms of background, we're talking about early help in the context of children and families, and we've got a statutory requirement to provide that. So under the statutory guidance, working together to safeguard children, we have to provide early help to children and families. That's providing support as soon as a problem emerges at any point in a child's life, either kind of from their earliest years through to their teenage years. So we need to identify the children, undertake an assessment of their needs, and then provide targeted early help services. And that's a collective responsibility. It's not just on the local authority, but it's actually across the partnership as a whole. In order to achieve that in every area, the safeguarding partners need to have a threshold document, which basically sets out the framework for accessing help and services. And it may be useful just to kind of consider that briefly. So there's a diagram in the report showing the sort of the 4 different levels in our threshold document. So you've got the universal level. So it might be that needs are starting to develop in a family, but in the first port of call, well, actually the first port of call is kind of within the family and within the community. But the first level of the framework is universal services. So it might be a school or a GP, which is initially the organisation that's providing a bit of support for that family or helping to meet the child's needs. As needs escalate a bit, there might be a need to move to level 2 and additional support, and that's where actually that single agency on its own can't deal with the needs, and you need to get agencies working together. So you might then have a team around the family. So the school might be involved in, say, the GP and the health visitor and perhaps a housing provider, or whoever is the appropriate team of organisations to work together in supporting the family and trying to help de-escalate the needs. Sort of at the top end of level 2, it may be actually there's a need to put in a referral for targeted support. So that's the point where looking at an early help assessment and putting a referral in through the multi-agency safeguarding hub. By the time you get to level 3, we're looking at more intensive support. So we're up to that's kind of recognising the Children Act at child in need, and this is the point where we're starting to get a statutory involvement. And at the top end, at level 4, into specialist need, we're up in child protection. So actually, that's where you've got social worker and actually having to safeguard children from harm. So that's the kind of top end. But all the time, what we're trying to do is maintain needs at a lower level, de-escalate problems, prevent the situation of children and families getting worse. So we need a framework which is about achieving that. There's a diagram in the report which is showing just the huge range of different services that can be involved in providing early help. And I think one of the issues that we've had in Oldham is there's been a bit of a tendency to talk about early help and just focus on the sort of targeted support which is provided through the council and positive steps, and not to actually recognise that the whole spectrum of agencies need to be involved in doing their bit to provide early help. So getting over that message that early help is everyone's business. And linked to that, we've had a bit of a tendency for kind of early referral. I think maybe we've done a lot on sort of promoting the targeted offer, and what we've lost out a bit on is the sort of team around the family bit, that agencies working together with one of them taking a lead professional role to work together to prevent the need for the escalation into the targeted services. So part of the work we're doing around the multi-agency early help strategy is actually doing more to get all the different agencies to play their part and making sure that we're working at all the different levels of need. And the problem we had with the old kind of Oldham Family Connect brand was we were focusing just at that top end about the targeted support and the work alongside social care. And actually that was, with hindsight, that wasn't an appropriate thing to be doing, because we were focusing on one bit of the system and not actually thinking about how the system works as a whole. So that's why we've moved away from talking about Oldham Family Connect to thinking about multi-agency early help strategy. Just in terms of what we've got at the moment, we've got quite a complex targeted support offer. So the report goes through, we've got a range of services delivering that. So a family support team who work alongside children's social care at that higher end. We've got an intensive casework team who are working more sort of at the edge of social care involvement, trying to prevent families needing to get involvement with a social worker. We've got a lower level early help offer, which is a commission service delivered by Positive Steps. And then we've got some development staff who work alongside schools and other universal services to try and help them to fulfil their roles and deliver the team around the family support. And one of the things that we'll be doing as part of the early help strategy is actually to simplify that system of teams, so it's clearer and they're working more as kind of one team with people with a set of different specialisms. In terms of developing the multi-agency early help offer, we've got a sort of strategic group which pulls together a range of different services, and a kind of big emphasis within it is about how we have a better integrated approach across education, health and social care, and with the range of other partners. We've got a sort of set of principles that we're working towards. So already said about early help being everyone's business and trying to really reinforce that we want to provide the earliest possible help. So basically whoever's best placed to provide it at that earliest opportunity. So they're the people who should be starting out unless we need to escalate later. So for example, if you've got a school who are working really closely with a family and have that relationship and they're best placed to provide the support, they're the people who should be providing it. And we should be minimising the handoffs between services, so you don't get that thing where families have to tell the stories multiple times to different professionals. And a general focus on what we're trying to do is how do we get better outcomes for children and really listen to the voice of the child as well, really hear about children's needs. A couple of things about our approach. So trying to have a restorative approach is very much about building working relationships, both with the families and also with the professionals involved, and also having an asset-based approach, which is about building the strengths of families. So rather than we're doing things to families, it's actually working with them and trying to build their capacity to do things for themselves. So we're sort of developing into turning this into a multi-agency early help strategy, which will have kind of coming through for approval later in 2020. A key part of that is linking in with the development of the district approach. So we're looking at, so at the moment I was saying a bit about having the complex set of teams. What we're looking at is having early help teams, one for each of the districts, and they'll have a set of skills within them, and they'll be working really, really closely with other partners in the districts in order, between the partners, together with the targeted early help staff, to provide the support that families need. But by getting closer into the district, closer to families, closer to other people who are working in those districts, we think we can offer a better service. So just in the nature of doing that work, there's a whole set of interconnections with other pieces of work that you may be hearing about separately. So I talked earlier about the continuum of need document. We're refreshing that. There's the recommissioning of the Right Start contract over the next couple of years. That's with health visitors, school nurses and children's centres, and we need to link that in with early help. Implementing the early years strategy as well. and we're reviewing the parenting offer. So there's a whole range of different interconnected different pieces of work that are going together. Finally, at the back end of the report, I've just put a little bit in there just about the experience during COVID. Just putting some statistics in there, which was just showing about how when COVID first kicked in and we started to see the measures on the restrictions on people's movements and schools closed, for example, we saw quite a dip in the demand for early help services, but that's kind of gradually increased as the months have gone on. So by the time we got to July, we actually had more demand for early help support than we did in the previous year. There's a bit of a breakdown in there showing the demand for some of the different teams, and one of the things I would highlight is that we've seen a lot of demand for domestic abuse services during lockdown. So we've got independent domestic violence advisors who support families around where there's a high risk domestic abuse. So basically where there's the highest risk of victims or their children coming to harm, and the independent domestic violence advisors are absolutely working at capacity at the moment. We're seeing a lot of demand for their support. So I've covered quite a lot of ground there. So what I tried to do is give you a feel for the direction of travel, the way in which we're thinking about how we're going to reshape the service in this next 6 months, and also recognise that we're having to do that in the context of the significant budget challenges we face. So it's how are we going to restructure early help in the context of there kind of being less resources around, but actually we want to deliver better outcomes. And realistically, the only way we're going to achieve that is if we get the better integration across education, health and social care, and the close working with other partners. So effectively, we're getting more bang for the more limited bucks that we'll have available. So that's a sort of quick run through the report. I'm happy to take any questions that you've got.
Sorry, are there any questions or observations for Bruce? Councillor Tour and then Councillor McLaren.
Thank you, Chair. Thank you, Bruce. Just one main question, obviously, is huge and quite complex. There's a lot of services working together. Just want to know, like, what kind of monitoring or support available to make sure that we are communicating and we're achieving what we're hoping to achieve. And you touched on the district level, but like individual ward level, how elected members are involved, or what kind of involvement that you're hoping to throughout this journey, this process. How can the elected members be involved, because we pick up a lot of casework, so just want to have a bit of an idea. Thank you.
Okay, so a sort of couple of points. That one of course is that as elected members and picking up casework, you can always pass early help referrals through, and obviously we get quite a number of piece of casework that come through to the teams from elected members, particularly some of the ones where maybe families are experiencing difficulties and need that bit of support in or assistance in getting the right support for them. So there's that very practical at the individual family level. Something that's in the report but actually maybe should have pulled out was about how we get sort of locality governance around the new model. So we've got, at the moment, there's a set of district advisory boards around children's centres, and so one of the ideas is that maybe we should morph those into thinking more about sort of a locality board in relation to children's services. So thinking about, okay, in the context of those areas and the wards within them, what are the particular issues, what are the particular priorities, what are the things that served the range of early help services need to think about, and what are the priorities for those areas. And I think the elected members' input into that locality governance is going to be really important, because it's getting beyond maybe the statistics that we can put together to actually you've got the on the ground understanding of, well, in my ward actually this is a real issue, or the reason why, I don't know, this is obesity or something is a particular issue is that, there's some of the context that you need to understand around it. So I think getting the elected member input at that sort of local strategic level is going to be really important.
Thanks, Bruce. Councillor McLaren.
Okay, thank you, Chair. A very interesting report, Bruce, which sort of follows on from the MASH report in a sense that we've looked at previously, and of course we've always had the opportunity to visit MASH, as it were. Perhaps we might need a visit to what we now call early help at some point, just to see how it's progressing, really, how it's evolving in this ever-changing climate in which we're now working. But I'd like to come back to the place-based initiative element that you touched upon. It's been something that we've been hearing about, as it were, for a period of time, but we don't appear to have developed, or at least I haven't seen what I would describe as a clear strategy. But I was interested in the element that in terms of how you integrate the DABs, as it were, the district advisory boards, and how we can pull the system together so that it's more meaningful. There's the PBI in Chadderton, to me, was sort of like an early help scheme, as opposed to which focused on intense help, as it were, but wasn't necessarily what was initially intended. The pilot seemed to have produced different aspects, as it were, in terms of how we take the place-based integration scheme forward. But it's still not absolutely clear as to how we, how we achieve that, and as you say, how we do that in a financially challenging climate. But one of the things that also emerged from the report was the fact that that you may not necessarily be relying on just one person to engage with a family, or that there might be a small number of professionals that have to engage with a family, for argument's sake. Now, is that the intention? Because we've always understood previously that we wanted to move away from the model that we saw some years ago now in the green room. I don't know whether you remember, I'm sure you remember that, Bruce, when there was umpteen engagements, and we've narrowed that down. So are we now looking for a sort of compromise approach where instead of just one professional engagement, there might be a small number of professional engagements with a particular family?
Right, covering quite a lot in there. I'll start with that bit about the sort of single professional versus multiple professionals. I suppose it's about sort of understanding the sort of levels of need. So the thing with the team around the family is where you've got services who are already involved with the family. So like a school, for example, a health visitor, GP, maybe their housing provider, and it's saying, at that stage, you've got those involved. It's about them having a coordinated approach to meet need at that sort of lower level. So it's a bit of, with the family's consent, a bit of sort of multi-agency problem solving. So saying, okay, maybe the school's the lead professional. They pull people together and saying, look, family's having these problems with the housing. Can you help with that? So it's a bit of multi-agency collaboration. It's when that multi-agency collaboration isn't enough, and you need somebody to provide some targeted support. That's the point where you're moving into having a dedicated worker who's holding the ring on it, and who's effectively, so obviously at the highest levels, that's a social worker. At the lower level, that would be a targeted early help worker. So they're then organising meetings, basically holding a plan, which is about getting other agencies to do their bit. And that's the bit that we'd replaced with that. You have to have like a drugs worker and a mental health worker and lots and lots. It's somebody who's doing that sort of that multi-agency coordination. You asked a bit about the place-based approach, and I think we're starting to move towards moving from the ideas stage into actually doing something. So I'm now starting to look at restructuring the internal early help teams around districts, with a view that they probably won't be physically located in districts. They'd operate centrally, but you'd have teams which work to particular patches, because a lot of what they do is actually going out and going to people's homes. So they'd have a really close working relationship with other professionals working in that area, but by having them sitting together or operating together, I suppose less and less we're sitting together, but operating together, we ensure the consistency of practice, and also it offers a bit of flexibility to support across teams as well. Interested also in your comments around MASH and early help. So we've now got a much closer setup within the MASH, like a children's services front door. In fact, literally last week, we've stopped having a separate telephone line for early help, and we've now got a children's services and an adult services well, it's the same phone number, but different options on the same number. So they're working much more closely together in a much more integrated way. So now when things come into the MASH for Children's Services, it's the same team looking at them, and it's then allocated to, with social care oversight, it's allocated to the most appropriate team. So I think if you kind of come back up to the MASH once we're in a position to be able to do that, you'll see about how some of that stuff's moved on quite a lot.
Right. Okay. Any timeline on, sorry, Chair, is there any kind of timeline that we might be working to on in terms of taking this forward?
Yeah, I mean, so the strategy we're looking to have signed off before the end of the year. I'm working on proposals around the restructuring for October, and it's then basically as fast as we can go through all the due processes. So certainly it will be well before the end of the financial year that I would intend to have teams who operate into those patches. And alongside that, we need to be looking at kind of getting the governance up and running around it as well.
Fabulous. Thank you. Thanks.
Councillor Hamlet.
Yes, Chair. Thank you, and thank you, Bruce, for your report. It was a good digest and a good read. It's just you mentioned that you're going to have this sort of place-based team as such. Well, it's not quite place-based if they're not based in the places that they're allocated in as such. So it's not. Yeah, it doesn't make sense to me in that regard because, well, so see it right. I'm trying to get my head around this. So you're saying that they're supposed to work with folks out in various districts. However, they're still being central. Right. However, how are they supposed to know the areas that they're working in? I mean, it's all right having us as elected members to point out, oh, that's a troublesome family, or that's a bit of a worry. Keep your eye on that. But, we could be slightly objected or whatever, there might be an agenda or it doesn't really matter. But the point is it's always good to also have people on the ground as well who are working in that area to also have either a similar mindset or to also pick up something as well. And to have extra folks and extra boots on the ground is always helpful. And I just think, well, to centralize everything, I get the point of, because there's space, there's office space, or at least somebody's on the other end of a phone or an email, that's fine. But I don't get the point of calling them place-based and then not actually sticking them in the areas they're meant to work in. Either they're sticking in the areas they're meant to work in, or they're not. And I just think, well, get them in their districts, get them alongside the district teams, and have them working there, so they can get to know the families, so they get to know the people they're working with, so they get to be out there helping out, and also, actually being that link, so that we're not having this, stress and strain on certain services, for instance, like foster cares or certain teams that carers, etc., so that we don't have that strain. So at least it can still be there to knock on people's doors or whatever and say, you're all right, how's things, and they can capture certain amounts of stuff that might be needed. But it just doesn't sort of sit right to say, well, they'll be there, they'll be helping out, and if they're needed, they can rush to a particular area, because if they're not going to be there, they're not, they're not touching on their communities. It doesn't quite make sense in my mind. Sorry if that was just a bit of a waffly rant, but I just sort of, yeah.
Just to add to that, Bruce, I mean, I've personally got experience of working with two of those PBIs, the one in Hollywood and then the one in Chadderton and Westwood. And similar to Councillor Hamlet, I think it'll be a step backwards if we centralise everything again, because I think what we need to look at is, yes, we need to make some changes because we've got limited resources, but is there anything that we could do with our partners? And those partners could be well placed to work in those neighbourhoods, and they take a lead on it rather than us council do, the local authority doing it, and the local authority could provide that support, sort of back office support to those teams, and I think you need to take that into consideration. What I don't want is all that good work that's been done over the last year or so in terms of the pilots, we don't take that good practice and carry on with it, to be honest with you. I don't really want to lose that.
I think, I mean, some really good challenge there about actually how it's, good point about, call it a place-based team and they're not physically place-based. These are staff who the nature of their job is that they're going out. Most of their work with families is done in people's homes, so they're going out, they're working with people in their homes. They might also be, say, delivering parenting courses, which could be in locations like children's centres, and they're also in and out of schools, for example, so working with other professionals. So the nature of their job is they're very out and about in the communities that they're working in. We've got, I suppose, COVID has just brought about a whole series of different changes. So now increasingly we're doing face-to-face visits again. So the teams are going out visiting people in their homes, whereas at the height of COVID it was much more telephone-based. But now it's much more, council officers spending more portion of the time working from home, and probably actually very little time in the office at the moment, and then they're actually going out and visiting people in their homes. And I think the sort of the direction of travel seems to be that actually we're going to retain that mix with people doing sort of a significant proportion of the time, so catching up on the paperwork, say they're working at home, and actually less need to be physically in offices. So you need a bit of continuity with your team where you're all coming together, and that's where there's a bit of a trade-off between the where's your physical office base? Are you based in a location in Royton-on-Shore and Crompton or wherever, or is it based centrally where you have the whole team? That's their office hub. But we just, all officers just got really used to now the operating on teams, building the working relationships over Teams meetings, and the fact you don't actually need to be physically sat next to people all the time to build those working relationships. So we've got an opportunity to do things a bit differently. But the teams will, wherever they're sat, they're going to be out and about in communities, knocking on people's doors, getting to know their area, and also building the working relationships with other professionals working in those patches. And then through involvement in things like the governance mechanisms, they should be having the contact with yourselves as elected members as well. So there's I suppose there's got a lot to work through around what is the way in which the district operating model works, and that's why I was kind of wanted to be up front with you about the way we're thinking about it in relation to the early help service, because I recognise you might have different points of view on it.
Right. Are there any further questions or observations for Bruce? No? Thank you for that presentation, Bruce. And you're more than welcome to stick with us if you want to, or you can go home and enjoy
go and have your tea,
evening. Right, thank you.
Okay.
Is the report noted?
Noted. Perhaps an update I'm not sure in terms of timeline, Chair, but perhaps an update at some stage.
Yeah, that would be.
Yeah, very happy to do that. I don't know I'm not sure what your meeting cycle is, but if you any point, happy to come back again.
I suppose
think
once
we're interested in how the scheme develops, Bruce, as you say, over the next sort of, by the end of this municipal year. So perhaps at the end of the year, perhaps in March, possibly.
Yeah, I think particularly given that actually, some of the concerns that were being raised at the end, it's given you another opportunity to air some of those issues.
Yeah. I suppose once you've sort of the new way of working, once you've come up with some kind of way forward, obviously it's going to go to the leadership, and once it's been there, if you could share it with us, with the scrutiny committee, that would be great, and then we could pencil it into our future work programme.
Yeah, very happy to do that.
If you can look at the dates in terms of when you're likely to go to leadership, and then after that, if it could come to us, that would be great.
Yep, will do.
Yeah, it'd be nice to see this again.
Yeah, is that agreed then? Yeah.
Agreed, Chair.
Yeah.
Agreed.
Thanks, Bruce.
Okay, thank you.
All right. Moving on to item 8, which is consideration of the council motion relating to ban on fast food and energy drinks advertising. That came to the last scrutiny meeting as well. We agreed at our last meeting to consider the item this evening, when we also have a copy of the draft healthy weight and physical activity strategy that we requested. Also, though, we are asked to note that the draft will need to be revisited due to COVID and the passage of time before it is subject to future formal consultation. Mark, could you present the report to us, please?
Yes, thank you, Chair. The report substantively comprises two documents, Appendix A, which is the report you had in July, and Appendix B, which is that draft healthy weight and physical activity strategy report, which, as you say, will need to be revisited in due course. So if we look at Appendix, I'll just very quickly talk through the report. So looking at Appendix A, that report includes a public health briefing on the evidence base around fast food and energy drinks, or high fat, sugar and salt food as it's described in that paper. And that paper itself recommends that any restriction or ban on advertising of such foods should be accompanied by measures to promote healthier options, and that in support of any ban, any breach of Committee on Advertising Practice guidelines around such advertising be referred to the Advertising Standards Authority. The report then goes on to present considerations against each of the action points in the motion. So paragraphs 2.2 to 2.4 considers the asking of Transport for Greater Manchester to consider implementing a ban similar to that in London. Details of the London ban, which includes the Transport for London policy, and an initial view received from Transport for Greater Manchester, including the coverage of the London ban, the use to which TFGM's advertising revenue is put to, and the possible support for promotion of healthier options which TFGM have identified, are all outlined in those paragraphs. With regard to the advertising or sale of fast food and energy drinks products on council premises, the council's current position is set out in paragraph 3, and that draws a distinction between the council's own immediate estate, which considers that those matters are addressed, and then the wider estate, which the council manages or leases to other bodies, and an extension of those policies to such property has the potential to lead to financial implication and would need a more in-depth consideration. With regard to asking other partners to make similar undertakings, while this might be undertaken in isolation, the briefing paper does note that promotion of healthy options should sit alongside this, and the draft strategy at Appendix B does propose a multi-agency approach and to be led by the Health and Wellbeing Board, which would provide a base from which to share the council's experience and to encourage others to adopt a similar policy. The final action point in the motion relates to government policy actions arising from the Taking Down Junk Food Adverts report, and these policy actions are highlighted at paragraph 2.7 in the report. Paragraph 4.2 had at that time suggested some considerations which the committee might want to make. However, the motion was referred to the scrutiny function for consideration. The committee might feel there's sufficient information now available to report back or to undertake some other approach on this motion. So it's over to you and the committee, Chair.
Are there any questions or observations? Councillor McLaren?
A very comprehensive report, Chair, I have to say, but it's the kind of issue that it's very difficult for us to make any significant progress in isolation, that we need to be able to work with other partners across Greater Manchester and perhaps even beyond, in order to be able to take this kind of scenario forward. Whilst you wouldn't disagree with the principles embodied in the original notice of motion, you sometimes wonder what thought might have been given to how we actually might implement it in practice. And clearly there are a number of issues, many of which Mark has outlined, that we need to take into consideration. So I wonder perhaps whether this is something that we might refer to Cabinet rather than Council, for them to give due consideration to, in order to, if you like, to evaluate, if you like, the extent to which partnership working with other authorities might be possible. It's not something that we ourselves, unfortunately, we can initiate. We can only make suggestions or recommendations. And whilst we might be able to suggest various scenarios, I wonder if perhaps we present a shortened version of this report, say, to Cabinet leadership, etc., for them to consider in order to determine how we might be able to address these issues by working with others. Chair.
Thank you for that, Councillor McLaren. I mean, I agree with you. I think this is something that Oldham Council can't sort of do on its own. We can only make small changes on our own, but if we did it at a GM level, we might be able to make a larger a difference. And in terms of the sort of intention of this motion is quite good, but to put it into practice, we need the wider leadership right across Greater Manchester to come on board to support this, and various other partners as well. It's not just a matter for local authorities, but other strategic partners to come on board with us to take this forward. To be honest with you, to make that difference that we want to make, that we want to make, if we want to make a real difference. So, like yourself, I would rather sort of take it to the cabinet and ask the leader to take it to discuss it with the 10 GM sort of leaders and see if we can get the support of them, and at the same time put a request into the Mayor of Manchester and ask the Mayor of Manchester to run a campaign on this particular issue, if he wishes to do so, obviously with the support of the 10 other leaders, and do it that way, rather than us trying to make some sort of minor changes that we could do as Oldham, to be honest with you. Councillor Hamlet?
Yes, Chair, thank you. I'm not adverse to that particular suggestion at all. What I was going to say is obviously, and I think it's probably better that way, because obviously then that way they can actually speak to TFGM rather than us asking TFGM to come to us and then we just do a Q&A session, then probably it leads to nowhere. Is that obviously, your suggestion was probably something similar lines of what I would have said. As long as perhaps maybe we just get something back from Cabinet just to say, what they've done with it, or report back, just to let us know how it's gone on, because obviously we don't want something to go through the machinations, through the mill, and then we don't know about it until either
disappears and doesn't come.
Yeah, it disappears.
I agree with you. Obviously, if we take it to the cabinet, and it has to go to the council anyway, and as part of the council, we can say, look, we want a progress report back to us within, I don't know, 6 months, whatever the time scale that we set ourselves. And it will need 6 to 12 months, to be honest with you, to go through all that bureaucracy rigor across Greater Manchester, to be honest with you.
If I just make, Chair, I do think it would be really important, and just to highlight the fact that there are constant links now to say that regarding obesity, that the survival rate, especially from those COVID cases, the survival rate from obesity is rather poor, especially those suffering from obesity. So if we can help to tackle obesity whilst we're fighting the pandemic, it can help to reduce mortality rates from COVID-19.
Yeah, I agree with you on that. Councillor McLaren?
I wouldn't disagree with anything that you and Louis have said, Chair, but I think to send the Cabinet 36 pages is a challenge for them. I think we've got to edit it down to 3, 4, 5, get down to the significant points, as it were. If we possibly can, it needs severe editing so that they can, if you like, evaluate the situation, the issue fairly quickly, if you like. And I think that's probably the best way to encourage them to give us some help and support, if you like. And I'm sure they won't disagree with the principle of the underpinning the original notice of motion, but I think we've got to make sure that as far as we can, we present them with a sort of, if you like, a simplified version that nevertheless highlights the issues that we're trying to promote.
Yep, no, I agree with you on that suggestion. Can I recommend to the committee that we ask Mark to sort of to minimise the report, and in conjunction with myself, and as Councillor McLaren made that suggestion, with us two, if us two could sort of work with Mark, and then we can take it to the Cabinet. Is that okay with the rest of the committee? Is that agreed?
Agreed.
Thank you. Are you okay with that, Mark?
Yes, thank you, Chair.
Item 9 is consideration of an action referred to this committee arising from the council motion relating to chatty checkouts and cafes, where we are asked to look into the possible introduction of this initiative in council premises and how it might contribute to social prescribing. The report highlights initial actions taken by the officers, and we will have a report brought forward to a future meeting of this committee. Do any members have any questions or comments on the report at this stage? Councillor McLaren, did you have your hand raised?
Well, Chair, I think this is another situation. While again, you wouldn't sort of necessarily disagree with the principles that that underpin the report, Brad. I think it'd be interesting to know what officers do think about the suggestions, and if we can identify what we're able to do up to this, up to this stage. I think that would be perhaps a helpful starting point, and then perhaps look at the response that we get to that, and then perhaps consider how we take it forward from there, Chair.
Mark, do you want to comment on that, or you don't have to? You don't have to if you don't want to.
Yeah, you had your presentation from Peter Paulson at the last meeting. I am in dialogue with Peter about taking this forward. It is being looked at through his team. They are dealing with social prescribing, so they are looking at it in terms of where it fits with their work programs and with their activities, and they will report back.
I accept that, Chair.
Right, okay, that's great then. Is that noted then?
Noted.
Thank you. Item 10 is the work programme for 2021. Is that, Mark, do you want to, are members okay? I'm assuming that you've all had the time to have a look at the work programme, and you're okay with it, or do I need to ask Mark to present it to you?
No, it's fine.
So, okay, the key point is that public business, the immunisation report is going to come to the October meeting anyhow. And then the other consideration was the anonymised safeguarding cases, as agreed in the committee in July. We need to reschedule that, and it might be like a training package rather than bringing it to the committee, because there'll be some confidential information within there in terms of those case studies, and some individuals could be easily identified. So therefore, the recommendation is that we don't actually bring it to the committee. So we have a separate session outside the committee to have a look at that. And I have asked them that as long as it's not repetitive of the safeguarding training that members have already had. If it's something that's added on and it's different to the training that we've done already, then fine, we'll go ahead with it. But if it's going to be similar, then I'm assuming there's no point of doing that, because we've already had that training and that was essential training as it is. Is that okay?
Agreed, Chair.
Thank you. The report is noted. Is that noted? Yeah.
Agreed.
Item 11. That's the date of the next meeting is 13th of October at 6 o'clock. Thank you for your attendance, and Mark, thank you for your hard work and for the extensive reports that you produced for us. And good night, everyone.
Good night.
Good night. Thank you, Chairman.
Good night. Thank you.
Yes, bye.
Good night.
Bye.
Good night.
Good night, everyone.
Good night.